Hi, everyone. It's great to be here. I'll be, I think, now the fourth person to say how wonderful it is to be presenting in a room as opposed to over Zoom. And also, I want to give a kudos to Terry for wearing heels today because I thought about that for 30 seconds and then realized not wearing heels for 2 years plus running a half marathon over the weekend would not go well. And now that there's stairs here that I see, like, really good decision on my part. So, but again, my name is Ginny Graves. I'm the Senior Product Owner at Association Analytics. And Association Analytics is a provider of business intelligence software for the association market. We have a product called Acumen that is designed to bring all of your data together into one place and provides the ability to make real-time data-informed decisions and allow you to take action with that data that you're using. But today I'm joined by Annette Moy, who is the Senior Manager of Data at the American Academy of Physical Medicine and Rehabilitation. That is a mouthful. And I've even had practice. And today we're going to talk about how our two organizations partnered together to use data analytics to put a spotlight on something that's really important in the country right now, which is the impact that long COVID is having on millions of Americans. So without further ado, I'm going to turn it over to Annette to talk a little bit more about our partnership.
Thanks, Jenny. Hello? Okay. So one thing that I love about data is it really helps you interpret the world and see things in a new way, and it also helps you tell a story. So what I want to do today is just tell you a story about how our response at AAPM&R to long COVID has helped us really even move past our organization and even our specialty to something larger. And hopefully we're bringing national attention to an issue and hopefully can be leading towards some meaningful change. AAPM&R, which I'm going to call it since it is a long name, we're the National Medical Specialty Society for PM&R, Physical Medicine and Rehabilitation. And really, what you really need to know about that, our physicians treat a variety of conditions, but they all have the same foundation, which is they help patients restore function to their daily lives. So that's kind of the common thread across all these different conditions. But we are a really small specialty. There's only about 10,000 members that are physician members of PM&R. So it's really a small specialty to be addressing, especially such a big issue as long COVID. So as you know, the challenges with COVID, with as individuals and as associations and as businesses you're aware of, with long COVID, it's much the same, but there's also some additional ones, which is especially early on in the pandemic, long COVID wasn't really in the forefront of national attention to the public. Our members were seeing it right away, but there really wasn't that much national attention to it or the public's attention to it. And with COVID, there's already a big tax on our healthcare infrastructure. So do we really have the resources to also be addressing long COVID as well? And it's really clear by now that we're 2 years into this, that COVID and even long COVID now aren't just magically going to go away where tomorrow is going to be normal again. So our members were like, how can we put a plan in place so we can move out of this crisis mode and really into having a plan to establish ongoing care moving forward? How do I advance this? So also just a background of where we were as an organization, just from a data side, we're really committed to and have been for many years being a data-driven, informed organization, both from our staff leadership and our physician leadership have really embraced data for many, many years. Our core thing is to know who our members are. And this is going to help us serve them. It's going to help us sell to them. It's going to help us with non-dues revenue, Terry. But we really just want to be able to do that with members, non-members, corporate support to really have that data. Internally, also, I'm working in the tech department. We want to make sure that we have something in place that if there is staff turnover on a data side, we're not in a lurch there. In the past year, we had a staff employee leave, for example, who did these wonderful, beautiful, brilliant reports. They were all very manual, multiple Excel documents you had to do in a specific order in order to get that result. To get a week over week, year over year report now is super cumbersome. And we have multiple staff people combing through her documentation to try to do that. So it's sort of like, how can we make this even easier from us from a staff point of view too? And then also, I just kind of want to say, I'm really interested in just personally about how certain big events really make an impact on our society, on innovations and things like that. In the past, we've had multiple wars that have spurred innovations. You know, you think about like World War II and how many innovations and new things came from that, from like the use of computers and radar to like really small things like the invention of M&Ms so soldiers could have chocolate in their pockets that wouldn't melt. You know, with COVID, you know, this is kind of like a World War II type impact that it's having on our society in a lot of different ways. If you think about it, I mean, back to food, you think about the restaurant industry and grocery industry, how much changes there are. From a technology point of view, it's very clear that there's two huge impacts, which is more virtual offerings and the acceleration and advancement of that, and also data and the adoption of data as individuals and organizations. And clearly, the more virtual offerings there are, the more data there is too. So these really work hand in hand. So, I mean, just the impact of an adoption of data, you have now senior citizens looking up a COVID dashboard to plan a road trip. Do I want to go to this state? I mean, that's huge in terms of the adoption of data. So, you know, if you're not thinking about data in your organization or in your business, you really should be. So AAPM&R's long COVID response was really a multifaceted plan. I'm going to talk about our PASC dashboard or PASC dashboard in a minute, but it really was a multifaceted plan. Within our organization, we have multiple departments working on this, our quality teams, advocacy, technology, communication teams, and then beyond AAPM&R, we have our AAPM&R members, also non-members, healthcare team, and beyond also involved with it. So our long COVID response is really a national call to action, a plan for resources, care for patients, and research. The call for action, we did do a letter to the president and to Congress. We had a national ad in the Washington Post. And then what I think is really interesting, this quality improvement initiative is a collaboration with 34 post-COVID clinics. This is patients, government representatives, PM&R physicians, other physicians, and other healthcare providers. They have monthly calls. 100 people are invited to this call every month. About 40 to 60 show up every month to discuss the methodology, and they are publishing guidance statements. They've already published one on fatigue, and coming up, the next publications are going to be cognitive impairment, breathing issues, cardiac, autonomic issues, mental health, pediatric, and neurology. So we're really trying to go with the symptoms that are most common with long COVID and start addressing those so that we can have some research for care. And then we also did our PASC dashboard. So really, as we have this plan moving forward in place, the idea was, how can we have a visual to go with this? How can we really highlight the issue that's happening with this? At this point, I had been working with Association Analytics, A2, on our contract for our data warehouse. And we were I think we were still finalizing that contract, maybe like a day or two away from it kind of thing. And we were like, hey, we have this idea for this long COVID dashboard. And, you know, people are coming to me from the organization. They're like, okay, let's go find a vendor. And I'm like, we have a vendor already. Why are we looking elsewhere? Let's keep our data together. So, what we really wanted to do with that, I knew about this because one of our requirements in picking a data warehouse vendor was somebody that could help us with third-party data. It's something that we've been interested in for a variety of different uses in the medical field. So we saw this as a really quick win that we could get on our data warehouse project, where as of right now, actually, we don't have our data warehouse up with our data right now. We're still in our data validation phase, but we're able to work on this long COVID dashboard in a parallel path and really get a quick win of something up, not only to use for this long COVID dashboard, but also to get buy-in for this data warehouse and in this data-driven organization that we can use. And we really have that visual and get buy-in from senior leadership too. Let's see, so this is our dashboard. And if you want to see an interactive version, Ginny will be outside later and she can kind of take you through it. But we have multiple filters set up here so basically long COVID, the estimate is that 10 to 30% of people that have experienced COVID could get long COVID. So it was sort of like, we know that this is a big issue, but how do you even talk about that when you don't have a number behind it? You know, like, how many people is that? How many people is that in my state? How many people is that in my county? So we wanted to really be able to do an interactive dashboard for that. So this one is the summary page, which is the national view. And then there's also a by state page, which also has a map. And then you can see the different counties. You can click on the different counties in the table and get your specific numbers. You can change the percentage. Like I said, it's 10 to 30% of cases. And I should say we did do that minus deaths. So, this is the Johns Hopkins data I failed to mention that we used as the base. So this is open source data that we were able to use and apply a formula to. And you can, it's definitely interactive. It updates daily. And we embedded this on our website. So we got it as an iframe from A2. And so the text on the page, we can change as we have different messaging and just have the dashboard embedded there. And our member reactions have been really positive in terms of people just really adopting it and really appreciating the work that we've done. I think beyond that, what's been really valuable to me is the press coverage that we've gotten. We've gotten some, initially right when it launched, but then we also had most recently a New York Times article that linked to our dashboard. And that to me just really shows the power of data, that this gives you something. You can take this idea that long COVID affects millions of people and transform it into something digestible, something you can use, something you can quote and direct to and link someone to, and now it's highlighting your issue. So moving forward, I want to say just sort of on a larger idea, we want to just continue to address our patients and physician needs nationally and locally. We want to support our members, the whole healthcare team. Internally on the tech team within our association, I want to foster a data-driven decision-making and also be adaptable to change as well. And specifically, we do want to add more third-party data. We're already in the works of adding some census data like age and gender. We're exploring some different things with that just to be able to layer and make the data more meaningful and more useful. Like I said, we're working forward on a parallel path to launch the data warehouse. And ideally, I would love to be able to connect our data with this third-party data so that we could really see the capacity versus need. So here's a county that has a lot of long COVID cases. Do we have physicians in that area that can address that need or not? Because then that really, again, highlights the gap or these deserts of care. And, our work just is not over. There's still not a national concerted effort to address the needs of people with PASC, which I don't think I actually even spelled out. I'm so sorry. PASC stands for post-acute, post-acute sequelae. I had it on an earlier slide, and I'm so sorry I didn't do it, but it's long COVID, but that's why I keep saying PASC. Man, my quality team is really going to nail me on that one. But it's the long COVID. That's what PASC stands for. Basically, is the Dr. Fauci term for it all. But we still don't have a national plan to address that. So we're going to continue our work. And I think that COVID kind of forced us to have this opportunity, and we really ran with this opportunity, and now we see what's possible. And I think we're just looking forward to see what's possible from here and take it even further.
Thanks, Annette. This was a really fun project to work on. So I always love hearing the updates and seeing the impact and seeing that the New York Times linked to something that Association Analytics developed. It's really exciting. So before we close for questions, I just want to spend a few minutes to share how we made this possible, because I'm sure that's what a lot of folks are wondering. So at the foundation of Association Analytics' product Acumen is a data warehouse, and that allows us to bring in data from pretty much any source system and store it, and then have it talk to each other in a way that it wouldn't be able to if it was all in the separate source system silos. So as Annette mentioned, we use the Johns Hopkins COVID data. That is an open source data source that is available through GitHub. So what we were able to do was just go out there and pull the data, bring it into our data warehouse. And then we have existing data from the US Census around geography. And then we also have existing data around dates and other other kind of like infrastructure related data. So what we did is we brought it all together and we modeled it together so that we could take the Johns Hopkins data and map it to geography data, map it to date data. We were able to take the assumptions that AAPM&R gave us around the 10 to 30% of cases resulting in long COVID, the need to subtract deaths from the cases to make this, and we were able to come up with different measurements and assumptions and put that into the data as well. And then we also met with the AAPM&R team probably like 3 or 4 times to talk about the requirements for this dashboard and to really understand what they were wanting. And what we came across is we were trying to make an impact. We really wanted people to look at this dashboard and be shocked by the numbers. So a lot of the design of what the final product looks like was based on those conversations of really trying to understand what are you going to do with the dashboard, what is the audience for the dashboard, and what is the intended use for that. So that is what we've done in the initial step. And then as Annette mentioned, we're also going to bring in additional US Census data. We're going to bring in data from their AMS and their additional source systems. And we'll follow the exact same process there where we'll bring in those tables, we'll integrate it with our data warehouse, we'll model it with the data warehouse, and we'll allow it to talk to each other. And that we're able to do this is really the strength of Acumen. Because if we were to look at all of this data separately, we wouldn't be able to create the type of product we've had. We wouldn't be able to have source systems that can't, quote unquote, talk to each other when they're in their silos, interact in the way that we're able to. And as a result, we're really able to combine all of these different key areas of insight and analytics together to produce an end product that is allow you to see everything at once, see the whole picture, and take more meaningful action as a result. So that's all we have today. I know we have some time for questions at the end. If you want to see the dashboard, if you want to play around with it, please stop by the Association Analytics booth. I'll be there with the dashboard up. And then also, if you have additional questions, feel free to reach out either to myself or Annette. Our email addresses are on the slide. So thanks all.
Great. I do have a few questions. So one question is, can you share a range of pricing and timeline to create this dashboard for Annette's organization?
I would recommend that if that is from a virtual attendee, that they email Mark Lowry, who is sitting right there as well. And it's mlowry@associationanalytics.com.
Okay. All right. So we'll post Mark's email in that. All right. Thanks for your question. So there's another question. I think it's for Annette. So how did you approach changing the culture at AAPM&R to be more data guided?
Sure. Well, like I said, I mean, it's luckily we already had a lot of interest in it, and we are still in process. And I would say my goal is for it to always be in process. We're also at the same time implementing a data governance strategy. So I'm working closely with that to really get all of our policies and procedures and getting everything shored up in that way as well. Because I think that really ties with this too. People really need to be able to trust the data. And if you don't have that, then you don't have anything. So you really need that good foundation. So that's kind of something, again, I'm working on a parallel path to do so that we can do that. But I think just the most that you can do is really upfront, just be transparent with your leadership about it, and also bringing them involved with asking a lot, like Ginny even mentioned, some of those upfront questions. A lot of times people ask you for things, especially on a data side, they have a certain report or a certain number that they want, but really asking them what they're going to use it for, what they want to do with it. And then when you are providing it to them, this is what it is, and this is what it means, and this is the story about it. It's not just like I'm, a monkey fulfilling your wish and request. I might not even provide to them what they even asked for, but I'm taking them on this journey, and that's actually enriching the experience. It's helping them ask better questions, and they're involved with the whole process as well. And then the next time it's a much richer experience too. So there's a lot of that, and I really want to make sure that we're providing the right level of information to the right person too. So as we move forward with our data warehouse project, I do really want to be aware of this is an executive summary level report. This is someone who's day-to-day really in there. They have very different needs, and I want to make sure that it's digestible to them. So again, it's just all a process, and taking staff, taking leadership, everything on that journey with you, I think is the main thing.
Great, thanks. Looks like this question's for Ginny. What different types of data can Acumen pull together?
Yeah, so we can pretty much pull any sort of data together, but there are a couple of stipulations. So one is we have to be able to actually integrate with it. So there needs to be open source, or there needs to be some sort of extract or API or way to talk to the file. But then the other thing that is really more around a successful integration and being able to successfully use your data is there needs to be some way to connect it to your other data. So if you're going to bring in some sort of third-party data that there's no way to model with your AMS data or your LMS data or anything like that, that's going to be difficult. It's not to say that it's impossible, but it's going to be very difficult, and you're probably going to have to make a lot of loose assumptions in order to model that data in a way that's going to work for you. So it's much better to be trying to combine data sources that have some sort of commonality between them. So for example, with the dashboard that we developed, as I said, we brought in the Johns Hopkins data that had county data, it had county FIPS codes in it. We had census data around geography, so we had those FIPS codes. So we were able to model those together. So you need some sort of common identifier like that to do it successfully.
Okay, great. And so what are the key foundational elements that must be in place to bring in all this third-party data, since you could mesh them all?
Yeah, so you definitely need a data warehouse, so the ability to host it somewhere, some sort of platform. We use a combination of Redshift and Amazon Web Services, but something like that. You need, I think one of the big things is the human resources from two sides of things. There's the ability to actually do the integrations, to do the coding, to do the modeling. That's very important. That technical know-how is very important. But you also need more of the, what I usually refer to as like a methodology know-how in terms of, and that's where I get back to, how can I bring these things in together and make them make sense? So to be able to code is one thing, but to be able to be thinking strategically about how you want to combine data sources is a much more, it's not necessarily difficult. It's a skill that takes a lot more experience and a little bit of trial and error. So you need something like that. And then the other thing is, if you bring all this data together, you need to have a plan for it. So whether you're working on developing visualization products, analytics products, whether you're going to be using it for reporting or some sort of outcome, you want to be really intentional if you're bringing all this third-party data together, all these different sources of data together, in terms of why are you doing this, what are you doing it for, because that's going to inform how you actually go about that process as well.
Right.
Yeah, I actually want to jump in on that, just because I think that's super important. I think with the data, you kind of think about like data just being cheap and it being digital. So it's just, let's more. And then you're like, and especially with the visualizations, like you're like, yeah, let's just throw up a bunch of stuff. But you're just like, just because you can, should you? And what are you using it for? How can you make this meaningful? So I think it's really, you just have to keep coming back to like your purpose, what you're using it for, and really making it meaningful.
And there's another question is, do you have a data governance team or policies you're working on with AAMP&R?
I'm not working on it with Association Analytics, but we do have I do internally have a data governance team and a whole setup with that. And I could talk to you about data governance too, if anybody wants to talk more about that in depth too.
And Association Analytics does offer data governance services as well.
Yeah, sorry. Yeah, well, I'm just not, we're not working together, but of course there are some principles or some overlap with that as well.
Great. So hold on. So the question is how easy it is to change the data?
So it's gonna be a little bit dependent on the source. So for example, if this was a source that was coming directly from AAPMR, like their AMS or an LMS or something, the ability to manipulate that or update it or change something about it is much easier than with third-party data. With third-party data, you are constrained by the data itself. And actually, Annette and I were just talking about this before the presentation during the break. With the Johns Hopkins data, the degree that Association Analytics has control over it pretty much stops at the integration because we're not the owners of it. They have a lot of great documentation about how to interpret it, but there's things that they're doing to the data that we can't control. And when we pull that data from that open source, kind of the raw data is what we get. And then we can do things on the back end to make it make sense. So for example, we're in the PASC dashboard, we're defining the population that can be considered for long COVID as cases less deaths. So we did that. So we can do things like that. But in terms of if we're saying, I want to change the raw data, there's a lot less ability of that. And again, it is dependent on the source.
Question for Annette. First of all, I've learned a new word today, physiatrist.
Yes.
I'd never heard it before, and I actually thought was that supposed to read psychiatrist or something like that? But the question is, when I look at your website, COVID doesn't come to mind. Okay, so was this a brilliant marketing decision to highlight long COVID and your association with it? I mean, you've obviously got excellent PR out of it also. But was it more of a market-led decision to go with this kind of a data analysis, or what brought it?
No. So with COVID, we kind of one of the initial things we did, I mean, with any healthcare association, I'm sure did a similar thing where you're like, let's have specific discussion boards put up so that our members can communicate to each other. Any healthcare person has been directly impacted with COVID in terms of their hours, in terms of the different patients they're seeing, the different roles that they've had to fill into. So we're like, so at the very, very initial thing, it was really just that. How can we support? We don't even know what challenges you're facing. Let's bring you together so that you can start sharing them. As they started doing that through that discussion board and also through our committees, you started hearing about it really even right away. I was reading different threads about we have these patients with decreased lung capacity even after they've survived COVID. What are we doing? So since physiatrists, like you said, really aren't, they're not like emergency room doctors, but they are dealing with COVID patients and recovering COVID patients. So they were really seeing that and recognizing this long COVID before we even had this national consciousness about long COVID. They knew about it right away. So our mind really shifted to like, what is our specialty? PM&R really equipped and uniquely qualified to help in this space, and what are our members' needs and what they're being asked to do and tasked to do, and do they have the support and the resources? And since they are so small, they need a bigger healthcare team. They need more government support. We need even non-physiatrists involved in this. We want to hear from patients. We need to get the government involved because we don't have the resources. That's part of it too, is just like we are small. So we're seeing the need. We really can recognize this and be aware of it, but we need help. And this needs to, again, like I said, be larger than PM&R, larger than AAPM&R, and bringing more people together. So it really did originate from that point of view, of just seeing this need of caring for patients, which does really fall with, like I said, PM&R is a wide variety of patients they serve, from pediatric conditions to wounded veterans to spinal cord injuries. There's a lot of different conditions, sports injuries, but it's really how to get someone functional again. And that's what our members' concern was with COVID is how to get these people up and functioning again, and seeing that some patients are just really, really struggling.
Thank you, Ginny.